inshallah, forwarding and hoping to add as much as we can in the field of neonatal teaching. So today we are going to talk about neonatal mechanical ventilation, but we will hit the area of strategies for lung recruitment, which is a challenge during ventilation in neonates. Is there any comment on the voice, or is it okay? Everybody is hearing me? No problem? Hello?
It's fine. It's fine.
Everybody? It's fine. Okay.
Yes.
Now
fine.
we're going to start. This is the hospital where we work, and this is our center of excellence, which has been launched 1 year ago. This is Saudi German Hospital Women and Children Center of Excellence, which we launched recently with subspecialties with the whole subspecialties for pediatrics. So I have no conflicts. Our objectives today is to talk about some historical notes about neonatal respiratory distress, when it starts and when they start to think about the ventilation as well. To give a general idea about respiratory support, how we can support newborns, even non-invasive and invasive respiratory support. To explain what's lung recruitment and lung recruitment strategies, which can be used either during ventilation or during non-invasive ventilation. And discuss also the non-invasive respiratory ventilation as well. Discuss conventional neonatal mechanical ventilation, some common modes, which is commonly used in neonatal units. And just take a note and discuss high frequency, general idea and general settings, high frequency respiratory ventilation, of course. Now we're going to talk about the historical aspects of neonatal assisted ventilation. So there are many ancient papers that have been recognized in respiratory problems in preterm babies and need for respiratory support. Point time 2698 and 2599 before Christ, the Chinese philosopher and emperor noted that respiratory failure occurs more frequently in children born prematurely. The papers from 16th century in ancient Egyptian reported increased mortality in premature infants, and the observation that a crying newborn at birth is one who will probably survive, but the one with expiratory grunting will die. And this is recognized very early and anciently. Also, at the Middle Ages, there is historical aspects also around 1000 Anno Domini after Christ means. The Muslim philosopher and physician Ibn Sina described the intubation of the trachea with a cannula of gold or silver. And Maimun, Musa bin Maimun, the common physician, wrote about how to detect the respiratory arrest in the newborn infants and proposed a method of manual resuscitation. This all was observations very ancient and in the Middle Age. But when the significant change and significant decision taken to improve this area of respiratory distress, this happens when Kennedy affected by this. So the base of premature son to the President John Kennedy and Jacqueline Kennedy in August 1963 focused the world attention. It gives a lot of attention to prematurity and treatment of hyaline membrane disease. So Patrick Kennedy was born at 34 weeks gestation by CS at Otis Air Force Base Hospital. His weight at this time was 2.1 kilogram and was transported to Boston, Massachusetts General Hospital, where he died from progressive hypoxemia at 39 weeks. Of course, with the tragedy of situation of Kennedy family at this time, which happened 3 months later by President Kennedy assassination, this stimulated further interest and research in neonatal respiratory distress and resulted in increased federal funding to this area. So started the era of mechanical ventilation and respiratory distress support and so on. So first of all, I would like to hit the term of lung recruitment, I want to be very clear for our colleagues. What's lung recruitment? Recruitment means hiring, means functioning. What's the lung function is doing? So lung recruitment is to help the lung to do its function. What's the lung function? The distension of alveolar sacs to collect the air, which include oxygen, and then this oxygen will be transferred to the blood through the pulmonary vascular veins, and then the blood which carry oxygen after that go to the left side of the heart, and then vice versa. At this point, the function of the lung and the alveoli ends. So to help the lung to do its function by alveolar distensibility and to contain more air which is needed for oxygenation. So recruitment generally means opening up collapsed alveoli to improve oxygenation. Alveoli can be collapsed either by actual collapse, like in hyaline membrane disease, because of increased surface tension, and can be also collapsed if there is any infection or fluids or pneumonia or consolidation and so on, as we'll see later. So lung recruitment maneuver is the maneuver in which temporary airway pressure is increased. So I'm increasing the airway pressure in the alveoli during mechanical ventilation, whatever the ventilation type, even non-invasive or invasive. Even in non-invasive, we can give the baby some sort of bead, which improve lung recruitment. And then during mechanical ventilation, so as to open up the collapsed alveoli and enhance alveolar unit involving in tidal ventilation. So anything increase, generally speaking, anything increase tidal ventilation will improve oxygenation and then improve lung recruitment. It will be clear one by one and slide by slide for the coming slides. So you can see here in this picture, at the right side, there is de-recruited lung. De-recruited lung means collapsed, and the alveoli there are collapsed and not distended and contains almost no air or very minimal amount of air, which will affect ventilation perfusion mismatching. It will affect ventilation perfusion and do mismatching, and this will lead to mostly to hypoxemia. On the other side, which is the left side, the lung is distended and there is a good bleed, and the alveoli is distended and contains enough amount of air. Of course, there are many other reasons for hypoxemia rather than only the lung. So if there is any systemic disease or pulmonary hypertension, the lung is recruited, but the pulmonary pressure and pulmonary vascular bed are very constricted. This is another era, but you have to keep in mind that this is part of the story and not the whole story. Lung recruitment strategies, treatment of underlying disease, removal of airway obstruction, colon aspiration. So you need to remove the obstruction to give a chance for the lung alveoli to distend and recruit it. And treatment of infection, if there is any pneumonia, it means there is consolidation, either bronchopneumonia, widespread all over the lung, or lobar or lobular pneumonia, which will take some sort or some sector of the lung and cause collapse. And after that, sustained inflation followed by decremental bead and stepwise recruitment by increasing bead or incremental bead, airway pressure release ventilation, high frequency ventilation, sigh, which has in some old modes in the ventilation, we have some sigh, and sigh in the middle will do some like lung distensibility and lung recruitment in between the regular breath settings of the ventilation. And prone position, even prone position can help in some situation for lung recruitment and improve it. So what's the advantage of lung recruitment maneuver? So of course it will increase the number of alveoli in the dependent part of the lung participating in gas exchange. So it will open more alveoli and distend more the distended alveoli. So it should be controlled and managed properly. It's not unlimited, it's limited according to the condition and the monitoring, which we will do by the monitor for saturation or for vital signs or the other monitors for the blood gas. Increase lung compliance. Lung compliance is very important. And if you hear about lung compliance, if you think about lung compliance, it's very near to the term of recruitment. So lung compliance refers to the ability of the lung to stretch. It is the expandability of the lung, the stretchability of the lung. Lung compliance can be calculated by dividing volume by pressure. So two factors affecting lung compliance, which is elasticity, and this comes from elastin in connective tissue, and surface tension, which is inside the alveoli. And this surface tension is very high in hyaline membrane disease due to deficiency of surfactant. That's why we are giving surfactant to decrease the surface tension. That's why we'll give the alveoli chance to distend and contain the gas, and then ventilation perfusion will happen. Reduce the intrapulmonary shunt, improving gas exchange into pulmonary capillaries, of course, by lung recruitment maneuver. How to get or grant lung recruitment? Lung recruitment can be performed in several ways. In delivery room with a TB's device, which is like ambo bag, but it has controlled pressure and fixed pressure all through the story, all through the time. So this will protect the baby later on from the risk of BBD, which is arranged and pre-prepared on a suitable pressure. Can be changed during the resuscitation, but this will give you a good lung recruitment for the newborn infant, especially soon after delivery. In the NICU settings, by using conventional or high frequency ventilation, of course, we can do proper lung recruitment, and commonly achieved by increasing beam, which is on nasal CPAPs, of course, or in the inspiratory lung volume by inspiratory loads or sustained inflation. Sustained inflation still needs a lot of research. By treatment of the cause, also you can improve lung recruitment, as infection, pneumonia, hyaline membrane disease would affect the lung distensibility in recruitment. So by treatment of the cause, we can improve lung recruitment. Disadvantage, short-term, of course, short-term physiological benefit, increasing intrathoracic pressure, compromising hemodynamics, because if you increase the pressure more than needed, it will reduce the venous return, and so refuse cardiac output for the duration, whatever. Hypertension and desaturation can be happening also as a side effect. Overextension of the alveoli and even barotrauma like pneumothorax or pneumodiasternum can be happening if you recruit the lung more than needed, or if the lung is friable or fragile by infection or due to any other reason. So this can be happening as a complication. And as most of us knows, when we start CPAP, initially, it was used by ET tubes, and the risk of pneumothorax and barotrauma was very high. Now we are using nasal CPAP either by mask or by nasal bronch, which helps to decrease this complication. So let's talk about neonatal respiratory support. How we support the neonate who needs respiratory support? So we can support by oxygen supplementation, which can be given by oxyhood or oxygen hood, which is a head box, which is not commonly used nowadays actually. So we don't have it anymore. We are depending on low flow or high flow or CPAP and other modes of ventilation. Or by oxygen mask in some situations, especially in ERs, you can find non-breathing oxygen masks, which can be used to support respiratory failure or respiratory distress. Nasal cannula, either ordinary or high flow. High flow called HHH, humidified, heated high flow nasal cannula. Differences between both: that nasal cannula with oxygen nasal cannula, the low flow is maximum by 2 to 3 liters per minute, and more than 3 liters it's high flow nasal cannula, which should be heated and humidified. So warmer should be there and the humidifier should be there. Also there is a very important point. The measuring diameter of the nasal cannula for high flow nasal cannula should occupy 2/3 only of the nostril. So it will create a physiological bead by itself in the lung to keep the alveoli still. So we'll continue the neonatal respiratory support, other way by CPAP, of course, either nasal CPAP or nasal mask or nasal bronch, or even biphasic CPAP, which is BiPAP. This is one of the most common CPAP machines used, which have biphasic CPAP and non-invasive ventilation setup and apnea monitor also. So we can use CPAP as continuous flow CPAP devices, or bubble CPAP, or ventilator derived CPAP, or variable flow CPAP like infant flow CPAP. It requires specially designed nasal approach. Biphasic CPAP, of course, you have double airway pressure, which you are providing through your machine. So you will deliver a beep like any CPAP, which will be 4 to 7, and you can deliver also high beep, not BIP, it's high beep, which will be 10 to 14. Sometimes you can increase up to 15 or 16. So it is a pressure controlled ventilation in a system allowed unrestricted spontaneous breathing at any moment of the cycle. Here we can see the bubble CPAP, which is almost a continuous beep, as you can see in the upper graph, upper side graph, which is a continuous beep and which is having in between a high beep to be given to the patients at different pressure, which will be almost 10 to 16, and the lower beep is 4 to 9 centimeters water. So more options, of course, varied and set respiratory time and also to set apnea. So now we're gonna hit the neonatal mechanical ventilation as fast because mechanical ventilation may result in serious complications. The decision to intubate and ventilate the infant should not be taken lightly and also should not be delayed. So the decision should be taken in proper time and not delayed, and also to avoid overuse of invasive mechanical ventilation to avoid its complications. The aim of any ventilation strategy is to support the neonate's respiratory system during compromise, improving lung recruitment with prevention of any short or long-term damage to the lung. That's why now we are going to have non-invasive ventilation more than invasive ventilation. Whenever the baby can tolerate and cooperate with the ventilation, so we use non-invasive ventilation, especially if he's breathing well and has no indication for ventilation. Understanding the principles behind the neonatal ventilation is very essential, and contact with manufacturer is very important because there are differences between ventilation machines. Key goals in neonatal ventilation: safety, comfort, and liberation. They are very important roles in neonatal ventilation, which should be kept in mind during use of mechanical ventilation. We have some indications for mechanical ventilation in neonates. We have absolute indications if you have severe prolonged apnea, if you have severe hypoxemia, with VO2 less than 15 millimeter mercury, or if IO2 more than 80%, or if you have respiratory acidosis with pH less than 7.2, or PaCO2 more than 16 millimeter mercury, or if you have neonatal CDH. CDH is congenital diaphragmatic hernia. At this time, you have to insert a large caliber OGD tube to decompensate the GIT, which a big part of it inside the chest comprising the lungs, and you have to intubate the baby and connect to mechanical ventilation because lung hypoplasia is expected in like these patients, and we have different strategy for treatment of CPAP. Indication, this is a relative indications for neonatal mechanical ventilation, frequent intermittent apnea responsive to drug therapy or nasal CPAP, early treatment when use mechanical ventilation is anticipated, deteriorating gas exchange, relieving work of breathing in infant with severe respiratory distress and high work of breathing, initiation of oxygenous surfactant therapy, and this is old. Now we are using LISA technique, which we have been discussed last year in the conference. And before LISA, we were using inshore technique, and coming on the way, MIST technique, which will be like nebulization technique for surfactant administration. So we are not using mechanical ventilation anymore when giving surfactant for the baby, especially if the baby can breathe spontaneously. So this curve will show us some will clarify the point of lung compliance. So as you see, the compliance is the elasticity or the distensibility of the respiratory system, including the lungs and chest wall. And compliance is volume over pressure, of course. So at the blue curve, you can find it has a better distensibility and better elasticity and good compliance. And the red one has less compliance, so higher pressure used to increase the distensibility and increase the compliance of the lung on the red curve. So the red loop. So you need to differentiate between these, because during mechanical ventilation, you will find the baby improve. So when the baby improve, it's a dynamic process, of course, and when the baby improve, his lung compliance will improve, and after that, you have to decrease your settings, especially the pressure. This happens especially when you use surfactant on some sort of essential pressure settings. So after surfactant, usually we are going to decrease gradually the pressure, especially the parameters leading to high tidal volume, because we expect that the data will improve fast after surfactant. So just keep in mind, it is a dynamic process, and the people will want to need the same pressure in all the time over mechanical or on mechanical ventilation. So this is also to differentiate between lung compliance in normal lung and hyaline membrane disease. So you can use in the lower loop, you can see in the lower loop on hyaline membrane disease, you need a very high pressure and the lung is not distensible and the compliance is very poor. Although in the normal lung loop, it shows that good lung compliance while using lower pressure than HMD. So this is very important. The lung compliance is the elasticity of the lung and capability of the lung to distend to contain more gas. So we have some common modes of neonatal ventilation. Neonatal mechanical ventilation, we will hit it. So it depends on the controlled function of the ventilator, commonly used by either pressure or volume or high frequency, and NAVA later on. So pressure controlled mechanical ventilation, as all we know, IMV, CMV, AC, BC, BSV, SIMV, and in each mode of these, we have some advantages and some disadvantages, and some used according to the structure and settings of the mode. Volume control or volume guarantee, which is commonly used nowadays, especially in extreme preterm infants, to control the volume of the gas entering the lung of the baby to prevent barotrauma and prevent later on bronchopulmonary dysplasia. High frequency selective ventilation, which is also commonly used, and even non-invasive high frequency now is available, and it's very effective. And high frequency with tidal volume, which is amazing machine and amazing settings added to high frequency. With this way, you can control also the tidal volume and decrease the barotrauma, which can be caused by high frequency ventilation, and also NAVA, which is depending on the neurological stimulation for the diaphragm to start ventilation of the baby and synchronize the ventilation more perfectly. It's still not commonly used for NAVA techniques. So this is the curves for positive pressure ventilation, which you can see in it. There is a trigger either by the flow of the air to the baby when the baby starts to take the breath, or after the trigger, the machine will start to give the BIP, which will take time almost 0.02 up to 0.1 from the second to get the pressure limit, which is set on the machine, and then for the plateau, which is the inspiratory time, which is usually 0.3, 0.4 seconds, whatever, depending on the condition, and then to start expiration, as you can see in our curves, either for airway pressure and also the volume. The volume is increasing when the pressure increases, the volume is increasing, and vice versa, and also the flow. So, positive pressure ventilation sometimes referred to as mechanical mandatory or intermittent positive pressure ventilation, and we'll see the modes and the differences. Now, continuous mandatory ventilation, it's very old and it's not used now, and it's also might be used now only during resuscitation when you give continuous mandatory ventilation either by TPs or ventilation which is built in the resuscitation or warmer machines. There is some machines, especially from the drugger, which they have built-in ventilation. This one is continuous mandatory ventilation. You will set up the machine on certain pressure, which is BIB and B and rate and IA ratio, and then the machine will give this to the baby, irrespective to the baby flow synchronization. So no synchronization in this machine until you reach with the baby to NICU and connect with the synchronized machine at NICU. Synchronization is very important to decrease the risk of bronchopulmonary dysplasia and barotrauma. Continuous mandatory ventilation sigh, which is in a rate of 2 to 6 inflations every minute, may help to open atelectated areas, and it's commonly used during mechanical ventilation of collapsed lungs. So synchronized intermittent mandatory ventilation, which is a common use mode, it's triggered by detecting the unit's spontaneous breathing effort through the flow sensor, and then synchronize the delivery of ventilator breath to match the unit own breath. So this will decrease the conflicts and barotrauma and the complications. In SIMV, the unit can take additional spontaneous breath between the ventilator-assisted breath. So SIMV can be used to wean the ventilator support and move toward extubation by reducing the breath rate and pressure. So decrease the rate gradually and decrease the pressure can be done on SIMV mode. When we go for PTV or patient trigger or assisted control ventilation, which is common mode, and we use it also for weaning, because in assisted ventilation, setup of the rate is a backup. So please always deliver the assisted ventilation rate is a backup rate. So if you set up a rate of 30, for example, for assisted ventilation, so the machine, if the baby is not breathing, the machine will give 30 breaths for the baby. Otherwise, if the baby is breathing, the machine is giving the same breath to the baby, but will help him in setting up the inspiratory time and the PIB. So for this mode, each time the unit starts to breathe, this triggers the ventilator to deliver breath or assist the unit breath at the set pressure, so it will help in the pressure and IT and inspiratory time, not in the rate. So the rate delivered and recorded is determined by the unit, not by us, especially if the unit is taking rate equal or more than the setup rate on the ventilation. So it's a backup rate. Always remember that, please. So weaning from ventilation support by reducing pressure, because rate is controlled by the unit, as we mentioned. PCV in pressure support ventilation, it's completely weaning, of course, it's completely weaning mode, where the unit breathing efforts are supported with ventilator breath set up to a predetermined pressure only. Mechanical ventilation assists the infant on breath by pressurizing the breast to set pressure support level. Full pressure support is a mode in its own right and may be useful for units who are weaning for their support. So in PCV, the baby will determine the rate and inspiratory time for himself. Only support of the pressure only will be done by the machine. So it's a weaning mode, which once we decide to wean, will decrease the pressure gradually until weaning happens. So basically can also be used in conjunction with other modes like SIMV mode, which ensure very spontaneous breath supported by ventilator at a set percentage pressure. Target tidal volume or VG mode, volume guarantee mode, which is a very common mode now, we are using especially in extreme preterm infants. BCAC with VG. VG will be 4 to 6 ml per kg, and will start by 4 and increase gradually up to 6 if the lung need more recruitment, and will control it by monitoring vital signs, lung distensibility, chest wall movement, and also, of course, the blood gas. So VG can be added to either SIMV, PTV, or EC. Desired tidal volume is set by the operator, delivered by ventilator using the lowest possible pressure. So we want to give this volume in the lowest possible pressure to avoid the barotrauma. So which ensures that the unit receive optimal tidal volume but at a minimal pressure to avoid the risk of bar trauma and volume trauma to the lungs. It should be remember that the measured peak inspiratory pressure for PIV is likely to vary, of course, because it depends on the baby and it depends on the elasticity and distensibility of the lung, which is the lung compliance, which changes in every breath. So if you see the ventilator in every breath, the baby will get this volume, but in different pressure all through the cycle. So this also will indicate improvement in the lung compliance. When you find your pressure, your volume is taken by a setup pressure, of course, 20, and by time the baby improves. So pressure of 15 is enough now to give the same volume to same certain volume in your machine. So it means this lung improves and this lung has dramatic improvement, and you have to think about also weaning. Manipulation of mechanical ventilation. This is some manipulation for improving oxygenation by increasing tidal volume. So MAP controlled oxygenation, mean airway pressure. MAP is controlling oxygenation. So oxygenation can be influenced by changing any of the variables affecting MAP, which is BIB, beep, inspiratory time, or ET, expiratory time. To increase oxygenation, increase MAP. Increase FiO2 in increments of 5 to 10% only, according to the condition. Increase MAP by increasing BIB or beep in increments of 1 to 2 H2O. Increase inspiratory time by no higher than 0.4 to avoid bar trauma also and for preterms. But in some patients with very stiff lung and wide lung severe respiratory distress, you might need this number. Consider adding B3 if on SIMV. Consider starting high flow oscillator ventilation if MAP and FiO2 significantly increase and no dramatic or no sufficient improvement in patient condition. Mechanical ventilation weaning goals, so or general rules, wean and extubate as soon as you can. When we think, always we ask our junior residents and trainee, when you think about extubation for mechanical ventilation, the always answer is, once I ventilate, I will start to think about extubation to avoid invasive mechanical ventilation as soon as we can. So wean and extubate as soon as we can. Early weaning will reduce the risk of lung injury, nosocomial sepsis, reduce patient discomfort, need for sedation, minimize development of oral aversion and subsequent feeding difficulties, facilitate parental bond and developmentally appropriate care. Whenever possible, use non-invasive ventilation rather than invasive to avoid complications. Weaning usually starts soon after initiation of mechanical ventilation if possible, mostly by reduction of FiO2 and pressure settings. Always keep in mind FiO2 and retinopathy prematurity to avoid any complication. So you need to set up your target SpO2 oxygen saturation to avoid ROB and oxygen toxicity. High frequency ventilation, this is a mode of ventilation that use breath rate or frequencies much greater than normal physiological breath rate with a very low tidal volume. So it's less traumatic than conventional ventilation. So always remember that high frequency is less traumatic for the lung tissue than conventional ventilation because it used tidal volume near to anatomic space. This is a picture of Sensormatic, which is one of the common high frequency ventilators, and we will talk about high frequency ventilation generally, just to give a note for our colleagues if anybody hit high frequency elsewhere in where you are working or practicing. So more commonly used high frequency ventilation where the pressure oscillates around constant distending pressure that in effect is the same as positive and expiratory pressure and equivalent to mean airway pressure. Thus, gas is pushed into the lungs So thus gas is lodged into the lungs during inspiration and then pulled out during expiration also. High frequency generates very low tidal volume, 1 to 3 kg, and as I mentioned before, there is some settings with high frequency with volume guarantee also you can use it, so you can set up tidal volume, special tidal volume with high frequency. That's generally less than the display as mentioned. Indication of high frequency ventilation, rescue following failure of ventilation in infants, especially in BPHM, recording acceleration, and pulmonary hemorrhage as well. Early syndrome, pneumothorax, and interstitial emphysema, failure of conventional ventilation operated in infants, especially severe RDS, DRE, hyperplasia, induced coma, when we have use conventional ventilation high settings. Lung hypoplastic syndrome, congenital diaphragmatic hernia, endometriosis, also ventilation. These are the parameters of high frequency ventilation. First is the frequency. The frequency, each frequency represents oscillations, 60 oscillations, so 60 breaths for each frequency. So we usually set the range of 8 to 10. Now we have some new modes and new techniques, new strategies for high frequency ventilation by increasing the frequency more and more, even to 12, 13, 14, and even sometimes more, with decreasing the tidal volume. So decrease the tidal volume even more than the deep space. So decrease the tidal volume more and increase the frequency. This strategy succeeds in many patients by improving the lung condition and decreasing also the side effects and complications. So these are the parameters for high frequency. Increased frequency will decrease the tidal volume in regular and conventional high frequency ventilation, which doesn't have tidal volume preset setup. So usually if you increase the frequency, tidal volume will decrease as a result for that. So CO2 will increase, and this will cause hyper. And will decrease the frequency, so tidal volume will increase, so CO2 will decrease. And this is the equation for CO2 with concentration. High frequency amplitude and mean airway pressure, these are one of the settings, two of the settings for the ventilation. Amplitude is a variation around the mean airway pressure, also known as delta V or power. So affects the chest wall, it affects the chest wall and control CO2 elimination according to extent of chest wall balance and blood gas analysis. Mean airway pressure, the total pressure cm centimeter H2O within the lungs throughout the respiratory cycle, usually set 1 to 2 cm H2O, higher than the pressure required by convention. So when you decide to shift away from conventional ventilation to high frequency ventilation, look at the map. If the map, for example, is 14, use map 15 or 16 by increasing 1 or 2 centimeter water, and then decide later by monitoring your baby on the settings of high frequency ventilation. CO2 washout is mostly related to tidal volume generated during high frequency, which is very small, 1 to 3 ml, because we have high frequency and very fast breathing and high number of breaths. So tidal volume with high frequency is not to be close to dead space. When using VG plus high frequency, so tidal volume is maintained constant, so the ventilator modifies the delta V to prevent any change in tidal volume high frequency. So manipulation of high frequency oscillatory ventilation parameters to increase oxygenation, increase FiO2 of course, and increase MAP, which is mean airway pressure. Increments in MAP usually by 1 to 2 cm H2O. To decrease oxygenation when weaning, aim to get FiO2 to an acceptable level, reducing MAP in increments of 1 to 2 cm H2O as well. To clear more CO2, increase amplitude. So increase delta V in increments of 2 to 5 cm H2O according to blood gas and chest wiggle, or decrease frequency. The decreased frequency will increase tidal volume, will wash CO2. So this will clear more CO2 or increase the tidal volume. So to clear less CO2 or to increase CO2 means reduce amplitude in increments of 1 to 2 or increase the frequency. So this will decrease the tidal volume and increase CO2. Weaning high frequency, it can be weaned by decreasing the pulmonary airway pressure to 7 to 9 cmH2O, decrease FiO2 gradually to 30 to 40%. The patient can be extubated to non-invasive ventilation or to CNV if heavily sedated. Take home message. So generally, lung recruitment is the goal of respiratory support in neonate. Non-invasive ventilation, like nasal CPAP, high frequency nasal cannula, high flow nasal cannula is much preferred than invasive mechanical ventilation whenever useful and whenever available as well. Mechanical ventilators should be used within the goal of safety, comfort, and liberation. Weaning of invasive mechanical ventilation should be initiated as soon as possible. Always keep in mind cardiac, neurological, metabolic effects on the respiratory system and vice versa. Lungs are not working in separate world. It works within the heart-lung machine and the chest cage. And these are some of my references. And thank you.
Dr. Mohamed, thank you very much indeed. Thank you very much indeed for your illustrative presentation.
Trauma code, main building, first floor.
Thank you, Dr. Sam.
Trauma code, main building, first floor, emergency. Trauma code.
Yes, Dr. Sam, I can hear you. Thank you.
Okay. Do you have any calls or any emergency?
No.
Okay.
I'm in the hospital, but alhamdulillah, there is no calls now, and I have my team working there. Everything is under control.
Okay, that's very good. Thank you very much indeed. You make